and Dr. Hani Faris for the kind invitation to give this lecture. I will speak about spastic diplegia. As you all know, cerebral palsy is a non-progressive insult of the brain that affects the immature brain, affecting the motor development. That means if I have any non-progressive insult of the immature brain that produce any other neurological abnormality like blindness, like deafness whatsoever, is not cerebral palsy unless it affects the motor development. The central pathology is non-progressive, but the peripheral pathology is progressive, and that's why we see the progressive deformities of the lower limbs and feet and so on, secondary to the progression of the peripheral pathology. Geographically, spastic cerebral palsy is classified into different types. Diplegia means the involvement of the upper lower limb with predominant involvement of the lower limb more than the upper limbs. In this lecture, I will speak about the functional classification, gait pattern spastic diplegia, the different levels of abnormalities, and the basics of treatment of patients with spastic diplegia from the orthopedic point of view. As you know, the motor function of the cerebral palsy is classified according to the gross motor function classification system into level 1, where the child can walk and run without aids. In level 2, he walks and runs, but there is some difficulty in stair climbing and walking long distance. In type 3, the child can walk with aid, but for long distance he uses a wheelchair. Type 4, actually he is a non-ambulator, but he can stand and help in changing position by standing. And type 5 is completely bedridden. So in spastic diplegia, the child is usually lie within the levels from level 2 to 4. Usually spastic diplegia does not achieve level 1, who can walk and run normally, and cannot. They are not usually bedridden. They are not a level 5 gross motor classification system. It's important to notice in this curve very important point that a child from the age of 0 to the age of 5.5 or 6 years, there is progressive improvement and progressive development of the child. And after the age of 6, usually they reach a plateau in their development. This is very important point to be realized. I will mention in a few minutes. The treating team, of course, they are neurologists, physiotherapists, occupational therapists, and orthopedists. These are the main team treating cerebral palsy, but other specialists may be called upon request. The most important thing that all the team of the treating cerebral palsy share the same realistic goals of treatment and the same realistic expectations. What makes the patients fall in a mess that he hears something different from the orthopedic surgeon, different from that of the physiotherapist, different from that of the neurologist. So we have to share the same message to be delivered to the patient. We have to put a logical goals. That means not every child will be walker. Not every child will be able to move. Some will be bedridden, and we have to confess of this. Some will be level 4, some will be level 3, 2, and 1. The most important things in these graphs or these growth lines, they are not intersects. That means the child of level 4 after the age of 7 years, for example, he will stay as level 4. And our intervention, our surgical intervention, is to improve his situation in his level. But it will not shift him from level 4 to level 3, and not from level 3 to level 2. And also, because all the children improve throughout the first 6 years of life, it's very difficult to improve that. Any intervention we do actually add improvement to them, because they naturally have a natural history of improvement throughout the first 6 years of life. The gait patterns in spastic diplegia, there are different patterns in spastic diplegia. We have true equinus, recurvatum, jump gait, apparent equinus, crouch, and asymmetric gaits. We will see. What's meaning of true equinus? There is pure equinus, but the child can achieve full knee extension in mid stance. Once the child can achieve full knee extension in mid-stance, this means that this is pure equinus deformity. And mind you, not all cases of equinus equal cerebral palsy. We have congenital contracture of the tendon Achilles. The most important sign to differentiate between both is the delayed milestones of development. The child with congenital short tendon Achilles will walk at his normal age, but in cerebral palsy there is delayed milestones of development, of motor development. The second is knee recurvatum. In knee recurvatum there is equinus, but in addition there is recurvatum in mid-stance phase. The jump gait is equinus in addition to knee flexion deformity in mid-stance. The child never be able to achieve full knee extension in mid-stance phase. This to differentiate jump gait from true equinus gait. And the apparent equinus, there is flexion deformity, but this is mistaken for the presence of equinus deformity. There is no equinus deformity. It is just the flexion deformity that elevates the heel of the child, but the ankle is in neutral or 0 degree of dorsiflexion and plantar flexion. And lastly, the crouch gait, which is excessive dorsiflexion in mid-stance, dorsiflexion of the ankle in mid-stance accompanied with flexion deformity of the knee and the hip. These are the gait patterns. The last one is asymmetric gait. You find pattern in the right lower limb and another pattern in the lower limb. This has been called before as double hemiplegia, but it is now called asymmetric spastic diplegia. As we see, there are 3 phases or 3 gait patterns accompanied with knee flexion deformity. The first one, there is no flexion deformity. The other one is recurvatum, but the 3 have knee flexion deformity. So the knee is the key in spastic diplegia. With progression from equinus to dorsiflexion, the ground reaction force shift from anterior to posterior and become more knee flexors rather than knee extensors in mid-stance phase. The natural history is the development from the equinus and jump to the crouching gait. Usually, the younger children with cerebral palsy, the spastic diplegia, present with jump gait or true equinus gait. And usually the physiotherapist and many orthopedic surgeons are concerned with the equinus deformity and concerned with the shortening of the tendon Achilles. If the child is left just for his natural history, he will shift from this equinus to a dorsiflexion and the crouching. So we shouldn't hurry for lengthening of the tendon Achilles, because we will share in the rapid development of crouching and rapid development of more severe and disabling deformity. First, I will describe the deformities at different levels: the knee, the rotational deformities, and the feet. It increases the force of the quadriceps to maintain the upright posture. And once the quadriceps increase its forces, this will lead to anterior knee pain. لو أي حد مننا جرب يمشي بس 100 متر وهو عامل knee flexion هيعرف يعني إيه. Knee flexion will cause severe patellofemoral pain and will produce patellar tendon elongation, increased incidence of osgood-Schlatter, and sometimes and many times we see stress fracture of the lower pool of the patella. The causes of knee flexion deformity, usually it is said that a quadriceps weakness, and usually use stresses in your exercise to strengthen the quadriceps, but actual hamstring overactivity and reduce the ground reaction force or malalignment of the ground reaction force vector, as we'll see. First, the hamstring. Normally the hamstrings act as a decelerator for the progressive foot lower limb in swing phase, but in stance the hamstrings actually act as hip extensor. In hamstrings in cerebral palsy, they are short or active throughout the phases, and this prevent throwing and prevent increasing the gait or step length during walking. It's important to differentiate between hamstring spasm and flexion deformity or fixed flexion deformity of the knee. If the child during hip extension, the knee couldn't be extended, this means that the child has fixed flexion deformity of the knee. It is not just hamstring spasm or hamstring shortening, because if there is hamstring spasm or shouldering, once I extend the hip, the knee should achieve full extension. And we discover the flexion or spasticity or shortening of the hamstrings when we flex the hip 90 degree, and then notice the limitation of to achieve full extension of the knee and the increase of the popliteal angle. So it's important to differentiate between hamstring shortening here and fixed flexion deformity of the knee, because the treatment is totally different. When the knee is preventing walking, اطفال ممكن يقول لنا عندهم فليكشن ديفورميتي اوف ذا ني، واحد هتقول ده هتعالجه وتعمل له كوركشن اوف ذا ني ديفورميتي، والثاني هتقول لا مش هعمل له حاجه. ازاي اقدر افرق ما بين تشايلد عنده فيكس فليكشن ديفورميتي واقدر اقول ان ده الفليكشن ديفورميتي منع المشي وواحد لا؟ If the child is able to walk on his knees, this is the good test. If the child is able to walk on his knees, then he will benefit from surgery to correct his knee flexion deformity. Like this other girl, she has fixed flexion deformity, but she is able very well to balance herself in her knees. This patient will benefit from surgery. If we do surgery for flexion deformity of the knee and the child is not able to stand on his knees and walk in his knees, he will not benefit, because after surgery he will spend a lot of time or most of his daytime in sitting position, and this means recurrence of the flexion deformity. And if I'm going to preserve my surgery and prevent recurrence, I will put him in splints, in knee extension, and putting him in knee extension splints will prevent his from good sitting posture. So the decision when to correct flexion deformity is important. Once the child is able to stand on his knees and balance himself on his knees, this is a good time to treat the knee flexion deformity. The message is not every deformity needs correction, and not any bent joint need to be straightened. You have to look the function of the patient. And if the patient is not going to benefit from the surgery you do, recurrence is 100% without any benefit. The treatment of hamstrings contracture is release of the hamstring contracture. I will not go in depth for surgical details, but we should release only the medial hamstring and not the lateral hamstring to avoid the development of recurvatum deformity. In presence of fixed flexion deformity is not just hamstrings contracture. In this case, we have the two supracondylar femoral osteotomy in addition to plication, sometimes shortening of the patellar tendon. The second cause important cause of flexion deformity is reduced ground reaction force. What is this? During upright posture, we stand with the passive mechanisms. The ground reaction force goes anterior to the knee, cause extension, and posterior to the hip cause passive extension, because the most strong ligament of the body is the iliofemoral ligament. So just balancing the tibia on the foot will produce extension of the knee and the extension of the hip with passive mechanism. What's important to keep this, to have a good plantar flexor to stabilize the tibia over a stable base, over a stable foot. So in this position, the ground reaction force passed posterior to the knee, causing flexion. But in a good position, the ground reaction force will be extensor to the knee and extensor to the hip in a passive mechanism without the need of any energy. And disturbance of this pathway of the ground reaction force is called lever arm dysfunction. And lever arm dysfunction is the loss of normal ground reaction force provided by foot during the stance or mid-stance phase. What are the causes of lever arm dysfunction? Is either rotational alignment or foot collapse. How? How the rotational alignment? Look, when the foot is looking forward, the lever arm or the length of the foot is long in prone position, because this is the position I walk. I don't walk with the hip flexor, so it is not logic to examine the rotation of the hip in supine position with the flexion of the hip. But we have to examine the rotation in extension of the hip, so this test is easy to be done in prone position. And if the foot is looking forward, you will see that the knees are inward. This means increased femoral anteversion. The second level of deformity is the tibial rotation, and this is tested by the foot thigh angle. Look here, this child walks without toeing. Notice that he has flexion deformity of the knee. without towing, because the lever arm has been shifted posteriorly and become flexors of the knee rather than extensors. And look at this child with in towing also have flexion deformity of the knee. This deformity of the knee is secondary to the rotational deformity and the shift and lever arm malfunction and lever arm dysfunction rather than pure deformity or flexion deformity of the knee. The other cause of lever arm dysfunction is the foot collapse or loss of the arch and over lengthened tendon Achilles. And this is a real problem we face. Early excessive lengthening of the tendon Achilles, especially in presence of proximal deformity or presence of proximal hamstring tightness. And the surgeon only do tendon Achilles lengthening. In this case, the tibia will fall anteriorly and the plantar flexor will not be able to stabilize the tibia straight up over the foot. And this will produce flexion deformity of the knee. The other cause is the severe flat foot and arch collapse. And this will shift the center of pressure of the foot posteriorly. And this shift posterior will shift the ground reaction force posteriorly and will cause lever arm dysfunction.
يعاني معظم هؤلاء الأطفال من ضعف الثقة بالنفس، ولذلك يجب الاهتمام بتشجيعهم ورفع معنوياتهم وتسليط الضوء على قدراتهم. وتتماثل أعراض هذا الاضطراب مع اضطرابات أخرى، ولذلك ينبغي التأكيد على أهمية هذا التشخيص عن طريق فريق متعدد التخصصات. عادة بيبقى تخاطب علم الطبيب النفسي، الأخصائي النفسي، والتربية الخاصة. في الخلاصة ممكن نقول ان اضطراب تشتت الانتباه والنشاط الزائد يصيب حوالي 5% من الأطفال، وله آثار سلبية على مجمل حياتهم الدراسية والاجتماعية والنفسية. وهناك 3 أنواع: غالبا مشتت، غالبا مندفع، أو مشتت ومندفع. ويصحب هذا الاضطراب باضطرابات أخرى مثل صعوبات التعلم أو القلق أو الاكتئاب. تشخيص هذا الاضطراب يكون عن طريق مقاييس التقدير، ويجب أن يكون عن طريق فريق تشخيص متخصص. العلاج المفضل هو الجمع بين العلاج الدوائي والسلوك المعرفي. لابد من تعاون الأهل والمدرسة وفريق العمل لتعديل سلوكيات الطفل. عدم التدخل المناسب قد يؤدي إلى عواقب وخيمة زي ترك مقاعد المدرسة مبكرا، مصاحبة أصدقاء السوء، استخدام المخدرات. وبصراحة أنا أشوف يعني عادة لما ببحث عن النت على فيديوهات توضيحية ببص على السايتس الأجنبي، ولكن بأمانة لقيت الأمانة الصحة النفسية المصرية